Welcome to the show. Today we're joined by Lauren Flowers, a certified registered nurse practitioner in hospice and palliative care. With over 12 years of experience, Lauren specializes in guiding patients and families through some of the most difficult moments in healthcare. We'll discuss key topics like de-escalation, code status, resuscitation events, advanced directives, and how to have meaningful conversations about death. This is a conversation you won't want to miss. Let's get started. Thank you for joining me today.
Thank you for having me.
Of course, no worries. So the reason why I came up to you and asked you if you wanted to come on, because when I did internal medicine at this hospital a couple months ago, I was in the ICU, and I would always notice that you would like come in and out of patient rooms, and I would be like, because I had the team that I was working with, the doctors, and then you kind of were like alone, just seeing all the patients, and I was always very curious, like with what you do, and you used to always wear bright pink.
Yeah, it's winter time now, so I have a sweatshirt. Yes, yeah.
And so you always like stood out.
Mm-hmm.
So I noticed that you would always go into the rooms of the patients that are having the most difficult times, or the patients unfortunately that are gonna deteriorate or going to pass soon, and that made me very interested. And I thought, you know what, I don't really know much about your specialty, so it would be nice if we got together and we talked about it so that I can learn and so that other people can learn as well.
Sounds good.
So I appreciate your time. So can you tell me more about what your job entails and the title of it?
Sure. I am the inpatient palliative care specialist, nurse practitioner, for the critical care division here at the hospital.
Okay.
So I work solely in the IMC, the ICU, and in the ED, or I also respond to rapid responses or code blues throughout the hospital as well.
Okay. And what do you do when you go see patients?
So it really depends on what the team is really looking for. Under normal circumstances, they want us to have, or want me to have, conversations regarding the escalation of code status, making sure that the families have a tremendous amount of support, because it's always a really intense situation. But being able to just kind of guide people through what is imminently happening to their loved one. It could be something where they're imminently dying, or something catastrophic has already happened, or we feel it is about to happen, and so we just want to make sure that everyone is kind of pulled together and supported and have good knowledge base.
That's very nice. Okay. So why do we need palliative care in the first place?
So palliative care takes place in a continuum. Where I fall in the continuum, unfortunately or fortunately, is towards the end. A lot of times where palliative should be implemented is a diagnosis. So even for something for lifelong type of illness, diabetes, palliative should be talked about, involved from the get-go, because it's about symptom management, it's about goals of care, it's about support throughout that entire trajectory. And if you get someone in the beginning of their disease process, you're better able to support them throughout that disease process. It doesn't mean that you have to get involved as intimately as I get involved at the end of life type of situations, but it is a tremendous amount of support. It also helps with having these conversations, with making sure that if someone is hospitalized, it impacts length of stay and all of those things. And just generally speaking, it helps with the cost of healthcare.
So do you only work with end of life, or do you go through that whole process, like from the diagnosis to the end?
Where I am with the critical care division, it's more along the lines of we're on the slope of the end of life. It doesn't necessarily mean that they are imminently dying at that time. But once you've had a pretty catastrophic ICU admission with intubation, pressors, and all of those types of things, and you're looking, that's usually the beginning of that sequela. Maybe it may be the first hospitalization, but chances are it's not the last. And so trying to get in there at that point, I usually am towards the end of that trajectory rather than the beginning.
Okay. And I hear two terms used always. One is palliative care and one is hospice. What is the difference?
So palliative care deals with the entire continuum. Hospice falls under the umbrella of palliative care, but there's criteria, and normally what you're looking at that situation is you're looking at less than 6 months of life expectancy if the disease were to progress on its normal trajectory. And it's a different level of support. Hospice has to deal with, they're very involved when someone gets to hospice. If it's home hospice, they'll come to the house, whether it be a facility, their home, wherever their home is, and gets more involved on a much more regular basis. Where if it's like an outpatient palliative person, they may contact a family once a month, or the patient at that point in time once a month, and kind of check in and see how things are going. But hospice is much more intense.
Okay, so hospice is the one that's when you usually have like 6 months left.
Mm-hmm.
That's when hospice gets involved.
Yeah.
Okay. And how do you usually get involved with patient care? Do you get consulted by a doctor?
Yeah, a lot of time. Well, I am a consultant, so I absolutely have to have a referral placed in the system in order for me to go see a patient. And a lot of times it can come, the referral itself through the system comes through a physician or from a provider. It could be an NPPA. But even sometimes the bedside nurse will be the first one to say, we really want Lauren to come and see the patient, or even social work will jump in and ask the provider to place a consult, and they usually don't balk at that. They usually just go ahead and place the consult and get us involved.
And when they place the consult, do they give you a reason of why they're placing that consult, and what is usually that reason?
Yeah, well, so in our system, it can delineate a couple of different things, and it goes from anywhere from goals of care conversations, symptom management, family support, or even if there's a consideration of placing a PEG tube, a surgically implanted feeding tube. We try to get involved in those conversations as well, because sometimes it's just not appropriate. And so those are the ones that the hospital uses. But 9 times out of 10, it'll just say goals of care, and it just means everything.
Okay.
Just come in and help us.
Everything. And when you go in, let's say you get consulted, and now you're going to go up to see the patient for the first time. Mm-hmm. What do you generally like to start with, or are there certain questions you like to ask to get a better idea of the situation?
Yeah, definitely. The first thing right off the bat is I introduce myself. I try to make sure that I'm able to sit and talk with families or the patient if they're able to, and try to make it as much of a casual conversation for as heavy as the conversation is going to get. I definitely try to make sure that people feel comfortable in talking with me. And so that's kind of the first thing, but and then if I'm either way, if it's patient or family, I want to know more about the patient. I want to hear about what's been going on over the last 6 months to a year, and kind of get a general overview. Was the patient, out doing her gardening last week? Was she eating? Was she drinking? Was she doing all of the things? What happened? Has this been a slower progression? I want the patient or their families to be thinking about the change that has happened, how great they were at this particular point to how that has changed to this point, to make sure that everybody is kind of understanding exactly where we are, and try to get more of an idea and have them focused on what a quality of life means for that patient before we even actually have the conversation about what quality of life is.
That's very interesting. So you really want them to know how better they were before as compared to now.
Oh yeah.
But the way I think about it is wouldn't that make them feel, I guess, worse? Like our loved one used to be very healthy and energetic, and now they're laying in a bed in front of me.
Yeah, for sure. But it gives them perspective. And I want to make sure that when I go in and I'm speaking to families that I'm setting really appropriate expectations. I want them to make sure that I am interested in what's been going on, to make sure that we are actually addressing the patient's core values, how they lived their lives, what they were able to do, what they found to be satisfying in their life. And that way, when decisions are made or need to be made, that people always have their loved one in their mind. It's not necessarily coming from their heart and from an emotional perspective, although it absolutely impacts them, but really trying to make sure that they're just, even right out of the gate, that things are very balanced and they're thinking about the patient and not themselves so much.
Okay,
it's
so
hard.
I'm sure it's very difficult, but So you're not necessarily always talking to the patient directly, but you're also talking to their families.
Oh yeah, if a patient's intubated and sedated, had a cardiac arrest or anything along those lines, a brain injury or whatever, they're not talking to me.
Right.
So it's a matter of making sure, and that's another key component too, of making sure that you're talking to the right person. We have a hierarchy of who we actually consider to be a surrogate or who's able to make decisions for our family members. And you always have to make sure you're talking to the right person, otherwise it's a HIPAA violation too. Right. So trying to delve into that.
Can you talk more about the hierarchy that you mentioned?
Sure. In the state of Maryland, when we talk about surrogacy and people being able to make medical decisions, usually, guardianship, if there's a court-appointed guardian, they're primary. But outside of that, it's a spouse, and then it goes to adult children. It can go to parents, depending upon age levels, and then different family members, and then also it can go to friends, if there's no family there.
Has it ever gone to that?
Oh, sure. Oh, yeah.
Really?
Oh, absolutely. Yeah. And then there's paperwork that needs to be filled out and things like that, just so that way that person actually accepts the responsibility to be a surrogate decision maker. We try to establish, a timeline and try to figure out exactly how involved they were in this person's life to make sure that they are an appropriate person to make those kinds of decisions. So it can be pretty involved.
So you go and you see a patient and they have 10 family members in the room. How do you know who to talk to?
Well, I go in and I start asking who people are. Introducing myself and you are, and seeing what relationship they are to the family, to the patient. The problem comes in, and God knows, I've dealt with it where a patient has 10 children.
Right.
And it's like, okay,
do?
Then you have to talk to 10 children. The idea at that point is, the goal is to narrow that focus down. You really only want to be talking to one person. So the idea is to figure out if you can get the other 9 to say that they don't want the responsibility. They cannot tell you who to talk to, but they can say that they don't want the responsibility. And so it kind of narrows down by the last man standing, so to speak. So.
And is that usually the oldest sibling, or does it change?
No, that's a great question, and no, it kind of varies. What I see a lot of times with our male patients, a lot of times it can be the youngest daughter, because for some reason they have a closer relationship and are able to talk and communicate well with one another. But a lot of times it's the oldest daughter more so than anybody else. But
really?
Yeah.
So not the sons.
Not normally, yeah.
Wow.
But it can be. It depends really on the family dynamic. But a lot of times I see the daughters stepping up and doing
That's nice. And you mentioned that there's sometimes a court-appointed guardian.
Yeah.
How do you know who's been court-appointed? Do they have to come in and present a paper to you?
Absolutely. 9 times out of 10, when a patient comes in through the ED, they've already established that there's a guardian. If they're coming from a facility or something along those lines, they already have the paperwork, and that paperwork comes in with them. Or we're able to ascertain in one way or another. The ED figures that out, registration kind of figures that out. There's an alert that's put into the computer system, and then we kind of go from there. I will normally contact the guardian right off the bat, because I need to see the guardian paperwork. If it's not already uploaded into the system, I actually have to see the paperwork, because sometimes there are different things that are put in there that you can and you can't do without court approval. Okay. So we need to know those things.
And I'm assuming you have to see the guardian in person too, or can you just do telephone?
Yeah, it can be by phone.
And what's their responsibilities at that point?
And that's why you need the guardianship paperwork. It varies. Sometimes they are the person who can actually make decisions. A lot of times they are the person that is the doorway to the courts, so the courts can make the decision. So it really depends on whatever that paperwork states.
Okay. And what kind of decisions are we talking about?
It can be anything from a de-escalation of code status, from full code, to anything outside of that. That's usually the primary, if we need to de-escalate in some way, and then they are absolutely necessary for hospice transition. Hospice is an elected service, so consent forms and things like that all need to be signed. It's not something that you can just kind of transition to. It has to be accepted.
Okay. And we'll talk about code status in a little bit. I just want to talk more about your job here at the hospital. Where do you find yourself mainly? Because you know the hospital is divided into the OR, we got the ED, we have the ICU, you know, inpatient. Where do you find yourself majority of the time?
Currently, I am critical care, so the majority of my time is spent in the IMC and the ICU. If the critical care team has been consulted in the ED, I can go to the ED if they place the referral. If there is a rapid response or a code, I automatically go to those, and if it's warranted, the critical care team will place a referral for me, and I'll take it from there as well.
Okay. And you mentioned, you know, sometimes you go in the room and there's almost, you know, 10 family members. If you don't mind, can you share us, you know, an experience that you've had? Or?
Oh, sure. Probably the biggest one that I ever dealt with was during COVID, and that no one was coming in the hospital then. And so we actually had, I had to have a computer translator along with Zoom meetings set up for, it was either 10 or 12 family members and a translator. Family members were literally all across the world, and had to come together to try to de-escalate and allow this this poor person to pass in peace. And that actually took us 3 different sessions to be able to de-escalate appropriately. I think that's the value that palliative brings in from an inpatient perspective, is that we take the time. The hospitalists, the intensivists, they just don't have the time to really deal with all of this, and so that's kind of
we are very thankful for, you know, the work you do here at the hospital, and I think it's very important. What does a typical day look like for you?
Well, I come in and I check my consult list right off the bat and make sure, you know, see if, you know, what's come in overnight or early in the morning. Under normal circumstances, I'll go right to the ICU and talk with the team, kind of figure out what's going on and who takes the priority, so that way I can kind of set up my day. I then go up onto our inpatient hospice unit and I speak with the hospice liaison to kind of see where what the unit looks like, in case we do have patients that need to be moved pretty quickly, and get them to hospice if we're able to. And then I go about kind of prioritizing my consults and going throughout the day. I will, you know, go speak with families. If they're able to be bedside, fantastic. If they're not, then it's phone conversations. I keep my ears open throughout the day, because for rapid responses or codes that get called, and kind of break up my day and escalate and go there. And a lot of note writing, as I know you're well aware of. And then follow up with my biggest priority is to make sure that I'm over communicating with the team. I always want to make sure that everybody is well aware of what's going on, from the bedside nurse to social work to the intensivist to, you know, whoever that looks like, that we're all on the same page and talking the same language, to make sure that there's no inconsistency and that families feel like we're all talking the same language, we're all from the same page.
Okay. And let's say you do get consulted for a patient, how often do you usually see them?
That's a great question. So that varies. It really depends on what's happening at any given moment for the patient. I try to, if my patients are able to get out of the ICU and go out to the floor and then be discharged, I may not see them when they are on the floor before they get discharged, but I'm stalking them. I'm definitely looking at all of what's happening from the notes and seeing kind of what's changing, and if there's something that pops up that needs to be addressed, then I'll go ahead and jump back in. But if they are, you know, if I feel that I've tied them up in a bow and they're nice and ready to go and the family feels supported, then I just kind of let them drift off until they go, and then we'll see them the next time.
And so once they get discharged, you usually don't, you're not in contact with them anymore?
So I always provide any patient family, especially those that have needed a lot of support. They have my phone number. I get phone calls from patient families 6 months after discharge, after they're discharged, because we've had such thorough conversations, and maybe during, you know, the initial conversation they weren't prepared or ready to de-escalate or to acknowledge that, you know, this is the trajectory, and their father, who, you know, has dementia, is going to be dysphagic. They're going to lose the ability to swallow. They're going to lose that, you know, they're going to go through all of that, and they're just not ready to accept that. But 3 months down the road, when their father forgets how to swallow and is having aspiration problems and all of those things, they kind of remember it's what Lauren was talking about, and they know that they can call me, and I call, they'll call me, and I'll support them and help them make any decisions that need to be made, or get them in contact with the right people to access resources and kind of go from there.
That's really nice. And I noticed that you mentioned de-escalation a lot.
Mm-hmm.
Can we talk about that? And I'm just going to check
Sure.
if it's still recording. But essentially, I just wanted to ask you, can you describe what de-escalation is?
Sure. So when I talk about de-escalation, I'm talking about code status. So a code status, it's just a word that we use here and we're across all medical institutions that delineates what we are supposed to do in the event of a catastrophic emergency. So if a patient's heart were to stop, or if they were to stop breathing, that code status tells us what to do. So a full code means that all efforts are going to be taken to revive someone and to sustain life, all. So it starts with CPR, chest compressions, intubation and mechanical ventilation, which is the tube that we put down someone's throat into their lungs and we connect them to a machine that helps them breathe. Could result in cardioversion, which is the only part, of course, on TV that could clear and you shock the heart. Central lines and pressors, so the large IV in the neck and giving them medications to keep their blood pressure elevated. All of those things result in an ICU admission. So when I talk about de-escalation, I'm trying to tell the family or tell the patient that those things may not be something that they want to endure moving forward. That perhaps kind of getting clear on what their goals are and figuring out, do they want us doing chest compressions? Do they understand that in order to do one good chest compression, it takes about 80 pounds of pressure, and we do 100 to 120 of those per minute? What they see on TV and what they experience in the movies, that's not it. And so that picture that they have in their head, you need to make sure that they're crystal clear on what they're asking for, because we're going to give it to them. If that's what I tell families that all the time, if that's what you want, we will absolutely do it. We just want to make sure that we are addressing those things appropriately so that their eyes are open about what they're actually asking us for.
And why would somebody not want full code status?
So I think as we go through a disease process, a lot of times, especially when you see these repeated hospitalizations, you see patients that decline significantly. I keep going back to dementia patients just because I deal with that quite a bit. But they lose the ability to swallow, so they lose muscle mass, they lose fat, they lose just their whole body structure. And when you think about a frail, cachectic person and a very fit someone coming in and physically putting their hands on their chest and doing that first chest compression, and what that can actually do to a human body. And sometimes we end up doing these things to people and we cause damage. We cause a lot of trauma to the chest wall. And so, okay, well, we're able to get their heartbeat back, never coming off a vent. And so really having that conversation to make sure that if those are the things that you want, we need to make sure that we're talking apples to apples, because people have a vision in their head that isn't necessarily accurate.
Right, yeah. And if that's your phone, feel free to answer it.
It's fine.
Okay.
Thank you.
Okay. So essentially, you go and you talk to the families about de-escalation, about changing the patient's status from full code, which means that we're going to do everything we can to keep the patient alive, to something less, like full. There's full code, and then what are the other terms that you use?
So there's full code. So So we have full code. We have DNR, which is do not resuscitate, so no CPR, no chest compressions. We have a DNR DNI, which is no chest compressions and no intubation. But along with that, you can say that you would want what is called non-invasive mechanical ventilation. So that would be CPAP, BiPAP, high flow nasal cannula. So you can kind of piecemeal that around a little bit. And so, making sure that you're talking about what each one of those things are is kind of what we're talking about. But under normal circumstances, a code status would just involve CPR, intubation, cardioversion, central lines and pressors. That would probably be the general
Okay.
We can get super specific, and I do that a lot, but that's usually the general thing.
Okay. And how do you usually approach a conversation about code status with patients?
I let them know that the reason that the team has asked for me to get involved is because we have some complicated medical issues and we really need to be on the same page. I ask families or patients if they are prepared to have a pretty intense conversation. I always let families and patients know that I'm going to be very transparent about everything that we're talking about. I truly believe that talking around issues muddies up the waters and makes things super complicated, and that's not my job. My job is to cut through it and make sure that we're talking apples to apples and we're talking as plainly and as frankly as we can. I always prepare families that I shoot from the hip. I'm going to put it all out there. But if I approach a conversation or say something in a way that hits someone wrong, they need to stop me, because we can certainly talk about it in a different way. I just have a tendency to be kind of blunt about it. I'm not scared of any of this. I try to hold hands, and I am as supportive as I possibly can throughout all of this. I cry a lot with my families through all of these things. But it doesn't lessen the fact that you have to have the conversations.
Right.
We're talking life and death at this point.
Somebody has to have the conversation.
Yeah.
Right. And how difficult is it for you to, do this for a living and always have these types of conversations?
I am so incredibly blessed. I love what I do. It is hard. It can be very challenging, but it's necessary. And this is going to come across probably even a little conceited, and it's not meant to be at all, but there aren't a lot of people that can actually have these conversations and do it well. And there certainly aren't a lot of people that can do it under high pressure when someone is literally crashing and burning. And so to be able to kind of pull it together and have those conversations in that stressful moment, I'm very lucky that I'm able to do that. And it is impactful. I look at myself as being, all of us, we play a role in the book of their life. And what I always want to make sure of is that when they look back at this chapter, or the family looks back at that chapter, that they felt supported, and that while it was very difficult, they were very happy that I was involved. And so that's kind of how I approach it.
Oh, that's very nice. And I know you touched up on this a little bit, but just to be a little bit more clear, what happens during a resuscitation event?
So the way that I have the conversation with the family is I explain to them that if the patient's heart were to stop, or if they were to stop breathing, the first thing that we're going to do is we're going to physically put our hands on them and get on their chest. We're going to start doing chest compressions. During that time, once chest compressions are started, there's usually a code that's called, the bell will be hit, the nurse or whomever is in there at the time will be doing that. And so then everybody comes running, the code car comes, they slap pads on people, make sure that they're doing all the things. So multiple people in rounds will be doing chest compressions, respiratory will be there, and at that point in time we're probably bagging the patient in order to try to get them as much oxygen as possible. They probably haven't quite been intubated yet because they're still trying to get the circulatory system and the heart pumping again. And then they're injecting medications, they're doing all of those types of things. And so it could go anywhere from a couple of seconds if they're able to get the heart started again, to hours of working on a patient depending on the situation. Yeah, it can be really bad.
Have you ever had a instance where a patient was DNR but the doctors did not know?
So I think that it does happen. It's never, the short answer is sure. The short answer is sure. It's happened. And it's very unfortunate when it does happen.
But are you in there telling them, hey, this patient is DNR?
It can be. Oh yeah, if I know about. Oh yeah, I'll definitely. That's the first thing. that is one thing during these conversations. As soon as that family says that they're de-escalating and that has been confirmed, and I'm able to make sure that I reiterate what that means to them and they're able to respond, the first thing that I do is I absolutely contact the team, let them know that the code status is being changed. I contact the nurse, let them know that the code status is being changed, and then I immediately go to a computer and change the code status.
Okay.
So yeah, that's incredibly important.
Okay. How can families prepare for the possibility of a resuscitation event for their loved ones?
I think from a general perspective, everyone on the face of this planet should have knowledge of what that means, and be prepared for that for anybody, including themselves. And you just never know what's going to happen. You can walk down the street and just drop. And so, I think the biggest piece when we talk about people coming in and out of the hospitals is just it's knowledge base. You have to be aware that this is always a possibility. And I also think that having the conversation with a medical professional who knows what all of those things entail is incredibly important. Because when we talk about code status, it is incredibly nuanced. And when people just think, oh, they're just going to pump on my chest and I'm coming back, that's not it. And so when you look at, and I know I'm jumping around here, but when you look at like an advanced directive or you look at these different types of paperwork, having a lawyer involved, that's fine if that's what you want to do. They have no clue what that looks like and are unable to have a really good conversation with you about what you're actually asking for. So I think talking to someone who is comfortable with the conversation and kind of knows what that would entail is incredibly important.
Right. And do these conversations happen in the hospital or within family members themselves?
I think yes, all of the above. I think podcasts like this are going to be incredibly helpful in getting information out and perhaps, piquing curiosity about, going to your primary care provider and having that conversation. If you have a medical professional in your family, talking to them about it and what that actually means. I'm not a huge proponent of Dr. Google by any stretch of the imagination, but at the same time, sometimes, doing a little bit of a shallow dive in the pool and getting some information can pique the curiosity for a deeper dive with someone who actually has a good knowledge base to be able to talk about it.
And I feel like a lot of people are watching right now and thinking to themselves, am I a full code? If I go to the hospital right now, what does it say on the screen?
100%. Unless you know differently, you are absolutely a full code. You will default to full code if they don't have the information stating otherwise.
And full code means resuscitation,
doing everything.
Intubations, IVs, everything to keep you alive.
Every poke, prod, test, everything. Your game.
Okay. Mm-hmm. Do you still have any patients that you still think about?
Oh yeah, I think about a lot of patients a lot of times. There are quite a few of them that stay with you. Yeah, they stay with you.
Okay.
Yeah.
What are advanced directives and why are they important?
So an advanced directive is just that. It's a directive that allows you, when you are at your best, to be able to tell people in written form what it is that you want as you're moving forward. What means the most to you. So we talk about resuscitation status and things along those lines. An advanced directive has multiple parts. For instance, a Maryland advanced directive has multiple parts. The primary piece that I'm always most concerned with is the first page, and that is where you determine who is able to speak for you for your medical wishes if you are unable to speak for yourself. If anything were to happen and we couldn't talk to you, who is the person that would be able to speak in your voice to tell me what I'm supposed to do? That is the very first page, and for me, that's the most important piece. And so if someone doesn't have an advanced directive, I like to fill that piece out. As you get further in the advanced directive from Maryland, it talks about, what means the most to you, what would you like to see, what would you not like to see, as far as, my advanced directive has, I have psoriasis on my scalp. I need my medication applied to my scalp so I don't itch. Because that's for quality of life. That's what means something to me. And so it gives areas for you to be able to proclaim those things on and kind of put out there the things that make you
right,
and make you comfortable.
When do we use advanced directives?
When do we use them?
Like in what kind of situation? Who looks at it? Is it
As a medical professional, that would
Okay.
that would more likely than not see it. Although, the people that you would make your healthcare decision maker, your power of attorney, your medical power of attorney, they should also have a copy so that they can see what it is that you want.
Okay.
You should be having that talk with them.
Okay, so do you use, so do you use advanced directives once a patient is, let's say, intubated and they cannot communicate with you anymore?
Yeah. Or if, again, going back to dementia, if the person is unable to have a reasonable conversation with you, you can go back and look at their advanced directive and kind of go. But it's a legal document, so it's
Okay.
something that you're bound by.
And you mentioned that the first page talks about what they would want medically. Is that correct?
So the first page is a healthcare decision maker, your medical power of attorney.
Okay.
After that, it goes into so an advanced directive talks about 3 particular topics. It talks about a persistent vegetative state, it talks about a terminal diagnosis, or an end-stage disease process. So those are the only 3 things that it covers, and that's why I'm not a big fan of the document, because it is incredibly nuanced. The advanced directive just talks about, do you want full code measures? Would you want artificial nutrition? Would you want, those types of things, or would you not want them? So, in my opinion, again, very nuanced. There's a lot more to be discussed in that realm. And so I think that's why you need to have a medical professional have that conversation.
Okay, and how do you make one?
Oh, you can get them online.
Oh,
Yeah, the Maryland State's Attorney General's office, they have advanced directive forms that you can just download and complete. If you don't do it with a medical professional, they need to be notarized, and that there's
okay. So people would sit with their family physician and
Yeah,
make the
absolutely.
Okay.
Yeah, it would be tremendous if it happened that way.
Yeah. So I wish everyone did that. Probably make your life easier.
It
right?
would, yeah. It would make their life easier.
Their life easier, right?
Mm-hmm.
What's your advice for someone who's hesitant to bring up advanced directives or DNR status with their loved ones?
Oh, that always makes me really sad.
Why does it make you sad?
Because if you are not able to have the conversation, your death can be absolutely everything you never wanted it to be. And I think that while we are able to make our wishes known and to have a thought process and have a good conversation about all of that, I think it's incredibly important to do those things. I think that's the problem, is that we're not talking about death. We're not talking about, and this is the one thing I say to my families all the time: nobody's getting out of this alive. We're all going to die.
Yeah.
Every one of us has a date. We don't know when it is or anything along those lines. But if you can have a little bit of control over what your passing looks like, I highly advise people to take advantage of that.
Okay. And how should they bring that up with their families?
Well, I mean, that's kind of personal. I mean, that's one of those things. I mean, you could, have mom out for a drive on a Sunday afternoon and be talking about how beautiful the trees are, and, or going to the cemetery to see, to visit loved ones, and kind of approach it that way. Have those conversations about, or bring it up for yourself. If you're with someone that you feel you're having a hard time having that conversation, talk about it for yourself. I've been thinking a lot about, what's going to happen to me if what happens if something happens and I get into a car accident and I'm on life support, and they're talking about, am I going to have to go to a nursing home and live in a nursing home for the rest of my life, and I'm not going to be awake or aware of what's going on around me or participate in the things that I like to participate in. I can't talk to my family. I can't bathe myself. I can't cleanse myself, all of those kinds of things, and really starting the conversation from a you perspective rather than a they perspective, then perhaps that can open up a better dialogue.
And you mentioned that, it is very difficult to talk about death and the whole process of dying. Why do you think it's very difficult for us humans to talk about that?
Oh, everybody they don't want to think about their own mortality, that's for sure. But again, it's what's going to happen.
Yeah.
So I think the more we talk about it, truly the more we talk about it, even in bits and pieces, it doesn't have to be right off the bat this huge involved conversation. But just approaching it and talking in bits and pieces kind of breaks the barriers down and makes it less uncomfortable. It's a reality that we all have to face.
Yeah, I was once reading this book and it said, life promised you one thing, and that is death.
Amen. And that's the truth.
Yeah. What language or specific phrases or stories do you recommend for having a compassionate conversation about death? Or, or you can give like an example of how you approached it with a specific patient or their family members. Do you give them like a storyline or for them to better understand it?
No, I don't. I try not to give storylines, and that's simply because this is their experience, and I don't want to taint that experience with something from me. I think that's, I don't know, it really, you can kind of feel out the person and kind of see where they are and all of that. With me, I have a script that I have used, that has evolved, but nonetheless that I use, and I just default to it every single time.
Can we hear that script?
Sure. Now that you caught me.
So we can put ourselves in a situation. Let's say, it's up to you. ICU, ED,
Sure.
Patient
Sure.
comes in and they're not doing well. They have their spouse standing right next to them and one of their children. And you're gonna go into that room because you've been consulted by one of the doctors because let's say, things are not looking too good for this patient. How do you begin that conversation with them?
So, I'm like at a loss right now, forgive me.
That's okay.
And I don't know why, because I do this all the time.
That's okay. I feel like I'm putting you on the spot a little bit.
That's okay.
We can come back to it later.
Let's come back to
Sure.
it in a second. And it's probably going to be one of those things where I'm just going to start type of thing.
Yeah, no problem. You see, I feel like a lot of different people that come from different backgrounds, different parts of the country, different parts of the world. Does that affect your job in any way? Because so many people have different perspectives about death and what death means to them. I know in Mexico, I think they actually celebrate death. That's what they do, I'm pretty sure. How does that affect your job?
Yeah, it definitely affects the interaction. I know, I worked at a hospital, a sister hospital to us, and, a very large Orthodox Jewish population. And, the value systems that are in place within different religious sects as well, that definitely impacts how they look at end of life. In those situations, it can be very, very difficult because a lot of focus is placed on end of life suffering and what the value of that means. And so a lot of times, everything will need to be done up until the very end, even until you've done a lot of damage to someone. And so coming to terms with that within yourself, knowing that you're going into a situation where you're going to hit an obstacle that you cannot overcome. You have to be very respectful of that and acknowledge and just kind of deal with those kinds of issues. But that happens across lots of different cultures, lots of different religions. Value for end of life suffering or end of life, just the general glorification of the longevity of life, regardless of what that looks like, can definitely be a priority, which for me can be very difficult.
Okay.
Yeah.
And this is something that I'm just curious about.
Yeah.
I'm very religious. And I'd like to know, based off of your experience, have you observed any differences in how people with strong religious beliefs cope with death compared to those who do not identify as religious?
So I think a lot of times what I see, and I tell families this because when they start speaking to you, kind of where they're coming from a religious perspective, whether I have a strong faith or I believe in God or whatever that looks like for them. People holding on to the Bible and things of that nature. And you have to find a way to meet them where they are. I remember very distinctly, I was working with a woman on the ICU, and she, not here, but she was dying, and her husband came in and dressed in his Sunday finery. I mean, he was just impeccably dressed, and he had a Bible, and we were sitting with a family meeting at the time, and he just kept saying, I have a merciful God. I have a God that can do all miracles. And I just looked at him and I said, have you perhaps stopped to think that your God is calling her? She is being summoned. She is being called home. And what you are forcing us to do is to deny him his child. And he looked at me, and at first he was very offended. And I apologized immediately. You could tell immediately. And I apologized immediately. And we continued with the meeting. And at the end of the meeting, about 20 minutes later, he asked for me. And I went over to his wife's room, and he said to me, I never actually thought of it that way. And he de-escalated her code status, and she passed that night. You have to figure it out and meet people where they are.
Yeah.
And offer a different perspective.
Yeah. Well, that's very powerful. I've never even thought about it that way. And what are some of the most common emotions family members usually experience when a loved one is nearing the end of life?
Fear, despair, sadness, guilt, lots of guilt. It runs the gamut, but what you hear all the time is, this is so sudden, this came out of nowhere. And 9 times out of 10, it's like, no, this has been going on for 2 years. It's been going on for 5 years. Whatever that may look like. This piece, this plummet off the edge is what is so sudden. But that trajectory has been slow decline. It's been a decline over a period of time. But they still never thought it was going to happen.
Right. We never really think or want it to happen. Yeah. But like you mentioned earlier, it's always going to happen eventually. Oh, yeah. When family members are going through those feelings of despair, guilt, and sadness, how do you usually guide them through those feelings and emotions?
I'm a good crier, but I don't necessarily let myself do that with all families, because sometimes you need to get in there with them and really experience that sadness with them, and let them see you as a human being, and that you do care and that you are vested in the situation. And other times they need for you to hold that space and allow them the opportunity to say all the things and tell all the stories and cry, and you be the rock for them to support them through that. So it really, you get to a place where you kind of have to flesh that out and see where they are, and just dive in however you're most comfortable in doing. I'm comfortable in either way. I'm a good crier though.
Okay. And do you cry in front of the patients and their families?
Sure, if it warrants it. Yeah. Oh yeah. Yeah. I truly believe, especially with when you do become so invested, they need to see your humanity. I mean, the families need to appreciate that, that you're not this table. You're not cold. You kind of get it. You know, you need to be able to be a little vulnerable with them when it warrants it. Yeah.
Right. And do you think the same applies for doctors? Because I scroll through Reddit and I see posts that say doctors shouldn't cry.
I don't know that you're ever going to see a doctor sit down and cry with a family. I don't. And that was a judgment call, and that probably not the best thing for me to say. I have not experienced that, but my interaction, I think 9 times out of 10, at least from the hospitals that I've worked in, that's why they call me. Is because it's difficult for them to have these conversations, and they may want to become emotional, but then they feel that they can't be. So I don't know. I think that would have to go from provider to provider to see kind of where they are and all of that.
So you wouldn't say that it's unprofessional for a doctor to cry in front of patients?
I wouldn't think so. I mean, that wouldn't be my take. I don't know. Perhaps the physician feels that way. And it also, I guess, depends on the rapport that they have. It's, you know, it's really hard when you come into an acute care facility, a hospital, and you're dealing with that. I mean, that's the one thing I do say to my families as well is like, you know, doctors change every week, nurses change every shift, social works change, you know, they change all the time. There's only one me. So throughout that continuum of the hospitalization, from the moment that I get involved until they are discharged, there's always me. Everybody else is going to flip back and forth. And so once I become involved, I am a tremendous amount of support because I kind of catch everything as we're going along. The docs, when they come in, they're coming into an update after, you know, they've been off for a week and they're picking up where someone left off, you know, kind of thing. It's hard. And then they've got a whole, you know, a battery of patients that they have to take care of. And you're talking about this one catastrophic situation, and how do they do that? I don't know. I think that's kind of why I have a job.
Are there some, like, I don't know how to really word this question, but are there some signs that indicate a patient is nearing the end of life? And based off, I don't know if this question is even appropriate, but do you know when someone is going to, do you have a feeling that they're going to pass soon?
Sure. Oh yeah, there's all kinds of signs. And 9 times out of 10, surprisingly enough, the patient will be the one to tell you.
Really?
Oh yeah, if they're able to, they'll tell you. Yeah.
What, like
they feel like they're dying. You know, I feel like I'm going to die. When someone, if a patient is doing not so great and they come out and tell you that they feel like they're going to die, believe them.
Really?
And believe them.
And when they say that, are they at peace with it? Have they accepted it?
That's situational. You know, and they're, you know, I had a patient, was it last week or the week before? And they, you know, I work during the week, I'm not here on the weekends, and over the weekend, you know, evidently he had been yelling that he wanted hospice. And it just didn't happen the way that it was, you know, the way that it should have happened, simply because we didn't have the coverage. And when I came in, I went in and spoke with him, and he was mad at me until I told, I'm here to help. I hear that what is it that you want? He said, I want to go to hospice and I want to die. And I said, okay, I'm going to do my very best and I'm going to get you there. And so went through and did everything that we needed to do. They got him to hospice. I went and saw him. He was happy to be at hospice, but he told me, he was like, I want to die, but I'm not ready to die yet. I need my lawyer. And they ended up the family brought his lawyer in. He was able to complete paperwork, his will that he wanted to complete. He signed the paperwork. He turned to the nurse. He said, I'm ready for some medication to make me feel better. He took a dose of medication. He was gone 2.5 hours later.
Wow.
Check. He had it all planned out.
Wow.
That's exactly how it went down. So when they're ready and they tell you, believe it.
Wow. And how often do things like that happen?
Yeah, I mean, that can happen pretty often. Surprisingly enough, when people have had enough, they've had enough, and they can absolutely will themselves to die. Yeah, it's kind of crazy. You can see patients who will be like in a comatose state, and then out of nowhere they perk up and they're like, hey, how are you doing? I want some water. Can I get this? I want a scrambled egg, you know, whatever. And talk to their family, call their family members. You start bringing people in and they get to talk to their family members and that kind of thing. And family's like, oh my gosh, she's doing so great. This is so fantastic. It's like, no. Take advantage of this. You've got a couple of hours of this. Once he goes back to sleep, once he drifts off again, you've lost all opportunity, because this is the last. This is it. And it's a rally. And then that's what you see. They perk up, they become involved, they drift back off, and they're gone.
I've heard, does this have a specific term for it?
We call it a rally.
A rally?
Yeah.
So is this like something scientific? Do we know why that happens?
I can't answer that question,
We don't know.
but it happens all the time.
Really?
Oh yeah.
Would you say it happens to every patient, or some patients experience it?
It definitely doesn't happen to every patient, but it happens often enough that when a family, especially when it's like home hospice or something like that, it's definitely part of the conversation that is had.
Really?
Oh yeah.
So essentially what's happening is this patient is not doing well. Suddenly they're doing amazing. And that's when you know.
That's it.
And how much time later?
It can be anywhere from hours to days.
Wow.
But once they drift back off again,
That's it.
that was it. That was your moment.
And we don't know why that happens.
No. But we tell families to look out for it all the time.
Really?
You know, if you see this, take advantage of it, have the conversation, say the things you need to say, do the things that you need to do, whatever that looks like for you, because when that happens and that's gone, you've lost every opportunity. That was your moment.
So it's like a gift from God.
It is a gift. It is 100% a gift.
These are your last moments. Cherish them.
Absolutely. Mm-hmm.
Wow. That's very powerful.
Mm-hmm.
Does this, let's say somebody's aspiring to be a palliative care nurse practitioner in the future, does this job affect you mentally, and if so, how do you deal with it?
Yes, it absolutely does affect you. And I really think it depends, where you are. For me, I started my palliative care career just before COVID. And then I dove in full-time, sole provider for a community hospital, quite literally the week before COVID hit. And since that time, once we got through the bulk of COVID, right after all of that, I am in therapy. I've seen therapists, religiously for every single week for probably 2.5 years, and then it went to bi-weekly, and I still see that person. It's just absolutely crucial. We in these scenarios, we carry a tremendous amount of weight,
Sure.
Because not only do I support a patient and their family, I support a team. The nurses, the techs that take care of the patients, they're witnessing all of this too. The providers that are there and are doing the best that they can. When, especially in critical care, and I can't speak for everyone else, but I know what I see when I'm in critical, because I was an ICU nurse for years. It's in the DNA to save. People go into medicine, they go into nursing, they go into healthcare because the idea is they want to save lives, they want to help people.
Right.
And so when it gets to a place where you're beating your head into a wall and you're actually causing harm, that's a horrible place to be. It causes a lot of, they say that it's burnout. It's trauma. It's not burnout. It's moral trauma. And so, doing that day in and day out and having to face that, it's heavy.
Sure.
So seeking help and assistance and guidance wherever you can is incredibly important.
What is the most rewarding part of doing your job?
All of those things that I just said. I think it's really important that people be supported, families and patients be supported when you're coming to the end of life. I think it's incredibly respectful and dignifying to be able to speak clearly and openly to people about what's happening. I'm a firm believer that knowledge is power, and you can't make good decisions based on bad information. And because of that, I'm able to be more me, because I am a shoot from the hip type of person, and I try to be blunt but respectful. And so helping through the transitions that I help through and everything, I think it just helps me be more me, and that is incredibly rewarding in this situation.
Okay. Have you ever questioned your career path?
Never once.
Okay.
Never once.
Even when times get tough?
Nope.
Okay. That's good.
I'm so blessed.
Yeah.
Mm-hmm.
It's fair to say that you see more death than the average person.
Mm-hmm.
Has your perspective on death changed now that you've done this job for so many years?
I think that my perspective on, I don't know that I've ever been fearful of death. It's an inevitability. I think what I fear most is the one thing I think that everybody needs to understand in the grand scheme of things. There are absolutely fates that are worse than death. 100% there are fates that are worse than death.
Mm-hmm.
And when you sit there and you think about it, dying is a release. And so if it came down to where death is the release and the alternative would be me being trached and pegged in a nursing home, unable to participate in the things around me, rotting in a bed with bed sores, getting infections, respiratory infections, multiple hospitalizations, all of those things, yeah, there's a fate worse than death. That is absolutely, in my opinion, a fate that is worse than death. And be careful, because if you don't do your advanced directives and you don't have the conversations with people and people don't know that that's not something you want, that's what you're signing up for.
Right. That's a very good point. And then just the last couple minutes here while we wrap up, I have some rapid fire questions if you don't mind.
Sure.
What advice would you give to healthcare providers who struggle with these sensitive conversations?
Well, I think if you're here at this hospital, you should come and talk to me, and we can kind of have those conversations over and over again until you get more comfortable with them. But I think being confident in your I think practice, really, it comes down to just practicing, finding a dialogue and a way to approach those things that works for you, and keep reiterating that. Talk to your colleagues, sit down and do a role play, have that conversation. You guys can go back and forth and try that in different scenarios with each other until it becomes second nature. If you have an inpatient palliative provider in a hospital where you work and they are comfortable with that, go sit and talk with them. I've been in hospitals where I leave my door open to residents and medical students and nurses and everybody all the time. I had lunch and learns in different units in the hospital, so nurses became more accustomed to not only participating in those conversations, but also administering morphine when you're talking about end of life and things along those lines, and make people more comfortable with all of that. So I think the more you do and the more you talk, the less stigmatized you are about it, and the less of a negative emotional impact it will have on you. So it grows comfort.
Does every hospital have a palliative care team?
You're supposed to. We should. It depends on the size, and it really depends too on the providers that are there. Some like the conversations and dealing with other people, and other not so much. So,
what's one piece of advice you'd give to a family member who has a loved one in hospice care?
In hospice, I would say no regrets. Spend the time, have the conversations, enjoy the company, whatever that looks like, because I think at that point in time, your days are numbered. It doesn't mean that it has to be, within that 6 months, because people can recertify, but it still means that you're on that trajectory. And so to make sure that you're optimizing everything, I'm just a firm believer in don't leave things left unsaid, because you can't reclaim that. And that's what you have to live with for the rest of your life. That's not on the patient, that's on you.
Right. Yeah. I feel like you answered this while we were talking earlier, but are you afraid of death?
No. Do I want to die? Nope. I'm not necessarily afraid of it. I'm afraid of ways that you can die, but not of death itself.
Okay. And what's your go-to method for unwinding after a tough day? Well,
I live on the water, so I spend a lot of time on the water, and that's very soothing for me. So that's a big one for me. In the summertime, it's water sports and things like that. In the wintertime, it's coffee, sitting on the deck, looking over the water, and doing that kind of thing. But I like to read, and I do yoga and meditation. I'm kind of getting into astrology and stuff like that. So,
is there anything specific you like to read about?
Right now, I am reading, reading a lot of astrological things, sacred contracts, things like that.
Okay, interesting.
Yeah.
When you've been a palliative care nurse for almost 5 years now, do you ever wonder what happens after we die?
So I have a lot of conflict on that, just because I had experiences when I was a child, truly had experiences when I was a child of I experienced angels and things like that. So, and I know that's from as children, a lot of us are open to things like that. Yeah. So, I do believe there's more. I think that's based on your belief system as to what that looks like. For me, I think that there is going to be an afterlife, and I think I'm going to see people that I love, that I've lost, and see my pooches that I've lost, and I think there's something good, you know.
Hopefully,
I think it goes on, yeah.
Yeah. And for anyone watching, whether that's a patient or family members, or is there anything you think that we missed that you would like to talk about?
No, I think, you know, the only real thing that I have to say about all of this, and it all comes down to communication. I think it's just becoming really comfortable in talking about everyone's life experience, and that is, we're born, we live, we die. What happens in between, you know, birth and death is individualized, but birth and death are, that's what we have, you know.
Yeah.
So I think getting comfortable and being at peace with having those conversations is incredibly important, because again, if you don't say, we're going to do everything to you, and that may not necessarily what you want. And if it's something that you haven't put in writing, make sure that those closest to you know.
Okay.
And that changes, you know. Like today, I want CPR. You know, I want to be put on a ventilator for a minute. That's for sure. But in 10 years, in 5 years, depending upon my health and everything, that could change. And so, you know, that's another, I'm glad that you asked me that, because it brought me to this. Advanced directives, while they are set in stone for that moment, they are fluid. So if you create a new advanced directive, you have a new advanced directive. If you change your mind on your code status, that previous code status goes away and that new one takes place. So you can change your mind, you know, as often as you need to, because your health is going to change over the course of time. So just make sure that you're either completing appropriate documentation and updating that, or you're talking to the right people and making sure that they know what you want as times change, because it is fluid.
Okay. I think that wraps it up.
Okay.
I really appreciate your time.
I appreciate yours.
And thank you very much for having this difficult conversation with me.
Thank you.